This talk is on Pterygium. What is your management? I'm joined by Professor Bert Jun from the Wilmer Eye Institute. We both see a lot of this sort of surgery. Certainly not as common as cataract surgery, but especially in climates where we get high sun exposure and Caucasian populations in the sun a lot. You see a lot of pterygium, and not just from work-related exposure, but also recreational exposure. And we all know we do pterygium slightly differently, and there's no perfect pterygium operation, but there's many different ways to do pterygium, and I'm sure we all strive to get the perfect result with no recurrence rate. So we've entitled this Pterygium, What is Your Management? And maybe Bert, if you want to ask the questions, and we can discuss the various answers as we go along.
Sure, I think it's a great topic, and I think that patients generally have high expectations if they come to you for surgery, because so many people have pinguecula or small pterygia that just don't bother them. But the ones that actually come seeking surgery, they tend to have more advanced cases. So these can be challenging to meet the patient expectations and to get a good result. But just to start with here in question 1, what is your indication for pterygium surgery? A, loss of vision. B, irritation or foreign body sensation. C, cosmetic. D, combination of above, or E, other.
So, when patients come to me with pterygium, often they're referred by either their optometrist or from their general practitioner. And in fact, I find a lot of the times the pterygium is small and it's not really bothering the patient too much, and they're just referred just for an opinion on what to do. So I actually find myself actually telling people that they don't need pterygium surgery, and might see them maybe 12 months down the track, or if it's really small, maybe just refer them back to their local practitioner and say, we'll come back when it is starting to bother you. But in terms of pterygium surgery, I suppose there's 3 categories I put them into. One, if they're having any loss of vision. So some pterygia really are significant. They're starting to grow closer to the visual axis, that they may be causing astigmatism, and I find it's usually a flattening either around the pterygium or in that horizontal meridian. And these people, really, for me, that is a very strong indication for surgery. In the second category, this foreign body irritation, and people talk about, they get redness of their eye, particularly over the pterygium, oftentimes okay, but sometimes flaring up, especially if their eyes are a bit dry or they haven't had enough sleep. Sometimes other people are telling them, oh, your eye looks a bit red, and so it becomes, I suppose, in that sense, more cosmetic. And that's a sort of third category, if the actual appearance of the pterygium is starting to bother them. Oftentimes it's a combination of those factors, and I think for me it's really about asking the patient whether they want anything done about their pterygium. Especially you get some patients that are, say, young females who are very aware of their cosmetic appearance, and I remember operating on one young lady who was her career was in modelling, and she said sometimes she was getting knocked back because her eyes looked a bit red. So,
wow.
Yeah, often times I ask the patient, do you feel you need to have surgery? Do you want to have surgery? And I never do surgery unless the patient actually wants it.
How would you describe the progression of pterygium? I mean, for me, it's sort of like, I think that by the time they get referred in, it usually is quite advanced. I don't think I have quite as many that are mild as you do, but as you indicated, you might send those patients back for follow-up closer to home or with their original eye care provider. But the issue is, for me, it seems like they just kind of come from nowhere. And obviously, we think about maybe the sun exposure as having a role earlier in life, or when the patients are younger, or maybe even over their whole lives. But how do you think they progress? Do they progress sort of gradually and progressively, or do they sort of progress in kind of a start and stop fashion,
Mm.
maybe years apart? Do you have a sense of that?
Yeah, well, I find generally it is a slow type of progression, like uh, especially in the Queensland population that I see, and got a very high numbers of Caucasian people in a tropical climate. So that they've estimated that maybe 1 in 10 Queenslanders have some form of actinic damage to their eye, uh, as you say, either a pinguecula or a pterygium. But yeah, with the progression, like I've seen patients who may have been referred for a pinguecula very very early on, and I'll tell them we'll go back to your referrer, and some of those have actually come back as a pterygium maybe 5-10 years down the track, which I'm not
Mm,
sure that is all that well documented, but
sure,
I've,
I think that's
I've
right.
actually seen that happen.
Wow.
It actually starts to cross over into that cornea, and then you start to see the typical vessel pattern of
Hmm.
a pterygium. Yeah, I suppose you do get the patients who are referred very late, and it's dreadful. You can actually see
Mm.
the pterygium crossing into that pupillary axis, and occasionally we even get the so-called kissing pterygia, where you get one from the nasal, one from the temporal,
Mm,
and
hmm.
uh, on those ones, it's a pity that they presented so late, because sometimes you take them off, and you do have residual underlying scarring, and that's more a permanent vision loss then.
Mm, absolutely.
Mm.
Well, I think that I'm always impressed by, just in general, the patient's ability to tolerate various problems. And oftentimes I would guess that those patients are many of them are referred earlier, but they just choose not to come because they just prefer to wait. You see some of
Just
these.
the other thing is that I think what you're getting at is etiology there for a bit. So a lot of the patients I see also have had other sun damage, like you see on their skin, that they're covered in sunspots. They might have had SCCs, BCCs
Hmm.
removed right
Hmm.
from their
Hmm.
face or their arms. Some have
Sure.
had melanomas removed. And it's quite interesting because in Australia, now this is something that may be different from the US. In Australia, the most common position for a pterygium is right eye nasal. And you think, well, why is that the case? Well, some people drive
Mm.
a lot, and they get a lot of sun from the right hand side.
Oh,
You get a
really?
lot of
Right.
sun from that direction. Other telltale sign is you look at their arm, and the right arm is covered in sunspots and freckles, and their left
Wow.
arm is relatively less affected. And it's because people drive with their arm on the windowsill,
Oh,
and
wow.
uh, and obviously plain glass to a
Hmm.
certain extent blocks UV. But if you wind the
Sure.
window down, stick your arm out, you're going to get a lot of UV from that side.
Well, I'd wonder if that was kind of similar to what is seen in the U.S., except on the other side, or in cars in countries where people drive on the other side of the
Left-hand
road.
drive,
That's
yeah.
very interesting.
But do you see
What
that?
about
The left-hand drive?
it's not been documented to my knowledge. So, I think there's less of the U.S. in that really high sun exposure zone. So, but you know what? I bet it could be seen with, looking at sufficient numbers of patients here. That could be determined. But to my knowledge, it hasn't really been looked at. But that's really an interesting sociological medical point. I wanted to ask you the question of, do you ever find yourself in a situation where you tell the patient, just keep an eye on it and come back if you notice that it changes, or if otherwise you become more bothered by it. And I guess the question really is, your sense of the reliability of patients to kind of follow these things and to kind of come back if they've changed.
There's two ways of looking at it. You can look at it from patient care point of view. Like I tell the patient, well, you can come back in 12 months, and some of them do. Sometimes I say, well, you can go see your referrer, either your GP or your optometrist for a check in 12 months. And I always like to document in the chart, saying that there's some sort of follow-up for the patient there.
Mm-hmm.
But you're right, patients, you tell them, we'll see you in 12 months, and they turn up 5 years later.
Mm-hmm. Mm-hmm.
And yeah, it's one of those things. But I find Pterygia is not so much of an issue because it is quite slow growing.
Mm-hmm.
Cataracts, probably in my way of thinking, are a bit more rapid developing, if anything. So yeah, if say I see someone with an early cataract, I'll say we'll see you in 12 months, and I'm probably more definite about that than I would be,
Mm-hmm.
say, with a Pterygium.
So what would be your recommendation for how to document the extent of the pterygium?
I do a chord measurement from crosses the limbus, so I'll
Mm-hmm.
have that in millimeters, and then I'll also measure from the head of the pterygium to the limbus in another sort of chord length, and that's my other measurement of in millimeters of the size of it.
Mm.
And I like to also document how far it extends into the fornix as well, because uh, often people just draw the head of the pterygium, but really you
Sure.
can actually see it going right into the semilunar fold. And
Right.
I like to document that as well, and also
Mm.
take a photograph of it.
Okay.
And it's another way, because you can measure it, you can write down the dimensions, and I also make a comment sometimes about the fleshiness. If it's very fleshy,
Mm. Mm-hmm.
like some of the older people, you see that they're quite atrophic. That it's actually
Mm-hmm.
quite flat, not too
Right.
vascular. Whereas in younger people, it's really thick and very vascular.
Sure.
So yeah, I like to make a comment of that as well.
Okay. Well, that's very good. That's helpful to get an idea of what kind of features one would actually make note of. But I don't. Yeah, that's really good about the fleshiness. I don't really make too much of a note of that, but
Uh,
that might indicate perhaps some level of activity, perhaps, or redness, whether if it's inflamed or something like that.
and sometimes
Uh,
you see that little iron line too in
sure.
front of the head. There's a stocker's line.
Absolutely. That's
Yeah,
right.
so that also indicates some degree of chronicity, and maybe those ones aren't going to progress so quickly.
Mm, mm-hmm.
And if you look
You know,
carefully at the
as
head too, sorry, but if you look carefully
that's
at the
good.
head,
Mm.
you see that whitening, it's sort of like that
Yes,
scar, and I
absolutely.
think that's a chronicity feature
Mm,
as well.
mm-hmm.
Sometimes you see little inclusion cysts in there. I suspect they're
Yes.
like little epithelial inclusion cysts.
Mm-hmm.
Sometimes you even see it almost looks like a calcified area. I'm not sure whether it's actually calcium,
Yeah,
but
that's a great point. I've
mm,
seen that before too, and now that you mention it, I think it
mm.
looks almost like a limbal girdle of boat at the tip, at the uh, leading edge,
Yeah, yeah,
almost like a degenerative change,
yeah.
probably with some calcification. That's very, yeah, those are all good features. Um, but I wonder if those would be correlated with, actively growing or more for stable findings. But
Yeah, I don't think anyone's ever studied that.
one could really do a lot of work on characterizing, the
Yeah.
features of pterygium. And as well as a geneticist, I wonder because there are lots of people in these various environments, and they don't all get the pterygium. Some people get them much worse than others. So I'm sure there's some sort of a genetic component as well as the environmental component that plays into it.
I never thought about that. I always thought it would be an exposure type thing. Minas Coronis in New South Wales. He's a professor at New South Wales University.
Hmm.
He's got a theory called the albedo effect, and he talks about uh, the sun coming in from temporal side across the cornea, and
Hmm.
the curvature of the cornea acts as like a magnifying glass and
Right.
focuses the UV in a wing shape fashion across the nasal limbus, and
Yes.
it's actually in the shape of a pterygium. If you shine
Right.
the light from the side,
Exactly.
you actually see it
Yes.
as a wing shape.
Yes.
focus. So that's his theory on why a pterygium looks swing shaped.
Venus has a lot of great theories.
Yeah. He's
He's
a
a
thinker.
very good thinker.
Yeah.
Absolutely. Um, okay, well, I think well, kind of going back to the genetic aspects that, would be interesting, and it might be easier to do in your population to get some idea of family history, for example, siblings
Mm.
or, mother and child or parent and child, that sort of thing, to get some idea. But I would expect that there would be some kind of susceptibility to it simply because, there are so many people who probably share that environment and yet
Yeah, it would be hard to tease out
they don't
the
get it.
the environment versus the genetics.
Absolutely.
Um,
Absolutely.
yeah, but it's often correlated to their skin damage too. Uh,
Right, right.
uh, have you seen people, but with pterygia that haven't had a lot of sun exposure?
Um,
Not so common, is it?
well, I mean, they've all had some. They have certainly have some skin damage,
Mm,
whether it's to the extent of having um, BCC or SCC. It's not always obviously that level, but yeah,
mm,
they always appear to have some kind of
mm,
skin damage. Then again, in some of the other sort of the Caribbean or the African populations, you might not quite see that much on the
mm,
skin.
mm.
But
Well, they talk about wind and dust as a potential etiology, maybe exposure to uh, petrol fumes, whatever. But
hmm hmm
yeah, they're all associated with outdoor activities, so
right, right.
eh,
It's absolutely hard to
maybe confounders there.
tease that out. Absolutely.
Hmm.
Okay, well, that was a nice introduction.
Yeah, number
Let's
one.
have a look at right number two. Now we're going to get into some real meaty topics here. So question 2 is, what is your preferred pterygium removal surgical technique? A, excision with bare sclera. B, excision with sliding conjunctival flap. C, excision with autoconjunctival scrap. D, excision with amniotic membrane. And E, other.
I'm fairly biased here because I've always done my pterygia with excision and autoconjunctival graft. And I suppose it's very much influence on where you trained and who you trained under. And I suppose a lot of my technique is based on Laurie Hirst, who's very well known for his pterygia work and
Mm-hmm.
has really done a lot of work into perfecting the pterygium removal. So certainly my technique isn't exactly what Laurie does, but it is in the same lines as what Laurie does. So uh, I always think that excision with, say, bare sclera, it seems to have a very high recurrence rate. Like that, they've
Mm-hmm.
done some studies earlier looking at pterygia that were done in, say, the eye clinic, and I can remember when I was a medical student going up to the eye clinic and they were doing a pterygium session and they had like 6 patients just at the slit lamp just tearing off the head of their pterygium with a basically an artery forceps, and
Hmm.
it was quick and it was not so pleasant for the patient.
Mm.
And they actually found a 80% recurrence rate. You
Mm.
could say, well, 20% did all right, but yeah, 80% is not acceptable. And I think most of us realise that your first chance is your best chance a lot of the time, and
Sure.
recurrent pterygia are often more difficult to actually operate on, and there's a lot more scarring
Mm-hmm.
involved. So, fortunately, by the time I got to be a registrar, that pterygium practice had stopped, and we were doing it in uh, the operating theatre by that stage.
Mm-hmm.
Although when I was a registrar, the technique was different to the technique I'm using now. So we certainly didn't take that much of the pterygium off. I remember as registrars, it was local anaesthetic. It usually either infiltration or a peribulbar.
Mm-hmm.
We used to do it as a day surgery type procedure, operating in a minor theatre. occasionally even in the back of the clinic. We used to do pterygia, but yeah, it was certainly a lot less extensive. There was this excision of the head of the pterygium, that there was no hooking of the muscles. There was a bit of cautery involved. There was no section of subtenon's tissue. We used to take the autoconjunctival graft from superiorly, but it wasn't a very big graft, and we used to stitch it in. I believe we were using 8/0 Vicryl back then, which isn't exactly as comfortable as say the 9/0 Vicryl.
Right.
But we're doing it under loops, especially in the outpatient procedure. So, yeah, you didn't have that finesse for dissection and the actual finesse in the stitching technique either. So, I'm sure a lot of those patients did reasonably well, but I think with the more extended removal that Laurie has popularized, and extended removal of the subtenon's tissue, it just takes the pterygium to the next level in terms of reducing recurrence and getting a better cosmetic result.
That's exactly right. I mean, I think that one of the issues that I have with the literature on this topic is that the definition of recurrence, and in our own experiences, we can have variable levels of success. An area of hyperemia, or a little bit of tissue regrowth onto the cornea, that sort of thing. It may be much less than the original, and I think for the right patient, that's enough. That's a success. But to have a native appearance of the eye after surgery, like you see in some of Professor Hirst's papers, that's a high level of success. That's higher than most of us would probably admit to for the majority of our patients. So I think, there is definitely room in the field for people to approach this very, very carefully and to achieve, basically ideal results.
Actually, we haven't discussed the sliding conjunctival flap, because that was in vogue for a little bit, probably basically after the bare scleral technique stopped being performed. And Laurie Hirst himself did a paper on the sliding conjunctival flap, and that actually came about. He was talking to one of our ophthalmic colleagues from just west of Brisbane, and this colleague was saying that he never saw any recurrence of his pterygium operations, and Laurie Hirst and one of the early trainees at the time went out to survey all his cases of excision of pterygium and sliding conjunctival flap, and he did indeed have a relatively good result. And they actually wrote that up in ophthalmology, saying what a good technique this sliding conjunctival flap was. So, in a sense, that was one of Laurie's earlier papers on pterygium technique, but he's actually stepped away from that. And the sliding conjunctival flap also didn't give you that great a cosmetic result, because when you slide the conjunctival vessels into that flap position where the pterygium was, it changed the direction of those vessels, and cosmetically certainly doesn't look as nice as when you use the autoconjunctival graft. And I've also found that with the sliding conj flap technique, often the flap is quite small, and I've seen cases where you can see the pterygium actually growing around the flap, and and getting a recurrence that way.
So do you think that would be sort of the main explanation for the lower success rate? Is just that they're limited in the size that you can achieve with it?
Well, part of I think the importance of the autoconj graft is that you're taking conjunctiva from underneath the upper lid, and that's conjunctiva, hopefully, that hasn't had much exposure to ultraviolet damage. So, so when you put it into where the pterygium's been removed, you're putting in a nice, healthy, non-actinic damaged tissue, and that stops it from stops the pterygium from recurring. Whereas if you're
Mm-hmm.
sliding conjunctiva, it's from adjacent conjunctiva into that pterygium excision site, and
Mm.
that conjunctiva may not be as pristinely UV non-damaged as say the
Mm-hmm.
one from under your lid.
Okay, no, that's a
Yeah.
very good point as well. Well, kind of along the lines of various autoconjunctival graft options, um, I've I've heard Professor Hirst talk about, and I think I've even seen a video of where he has retrieved tissue from the site of a previous autoconjunctival graft and used that for recurrence. Once you take the graft, can you take another graft from the same site?
Well, you see, the thing is that when you actually do an autoconjunctival graft from that superior conjunctiva, you're dissecting in between the plane between the conj and the underlying tenons. So
Yes,
as much as possible, you're not disturbing that underlying tenons.
right.
And because there's conjunctival stem cells in the superior fornix, the
Yes.
conjunctiva grows down, and if you preserve that tenons layer, it can grow quite normally back towards the limbus. So
Mm,
yeah, so if you wait 3, maybe 6 months after harvesting
sure.
the autoconj graft, the actual site uh, is looking almost back to normal, and
Right.
there's no reason why you can't take another graft from that
Very
site.
interesting. Yeah, so
Yeah.
I guess what that means is because, I mean, we've all done these and we're definitely seeking to dissect in that plane. I think that histologically, for example, it's hard to know how actually successful we are, perhaps. I'm assuming that we're always taking some bits of tenons as well as the fact that, you're taking the basement membrane of the conjunctiva and that sort of thing. So I suppose what's happening is that the remaining tenon serves as sort of a scaffold for these conjunctival epithelial stem cells to grow back over, and then over time they elaborate enough of a basement membrane to produce a I guess an amount of tissue or a layer of tissue that seems very much like intact conjunctiva. Now I've never had to do that, but um, I was surprised that it would be possible.
Oh no, it certainly is, and I've had patients, especially with these double-headed pterygium, where you've got a nasal and a temporal pterygium,
Hmm.
and we can talk about this a bit more, but in those cases, you actually need a lot of conjunctiva
Mm,
to cover the two defects. And
hmm.
I know Laurie's very keen on just doing one at a time, so he'll do, say, the nasal one first, take the graft, put it in, and wait 6 months, and do the temporal one, taking the conjunctiva again from that superior site. You can potentially take it from inferiorly as well. Uh,
Okay.
and so you can maybe use the superior conj graft to the nasal, and inferior conj graft to the temporal. But those double-headed pterygia, they're big operations, and
Hmm.
sometimes you're probably better off actually doing it in 2 stages, to do one first and then the other side. Mm.
Mm. So what would be your reservations for taking inferior graft tissue, just in general, even as a primary, so just as the first graft site?
Well, I certainly
I
know
mean, we're not.
that some surgeons like to take it from inferiorly because of the potential, if they need a trabeculectomy, that they say you might be disturbing the conjunctiva and causing fibrosis and scarring and reducing your success for trabeculectomy. And
Hmm.
if I was wearing my glaucoma hat, I would say that if you do a nice dissection and get that conjunctiva off the tenons without damaging the tenons, I
Hmm.
would say I wouldn't be too adverse to doing trabeculectomy, because trabeculectomy, as you know, is subtenons,
Hmm. Hmm.
and so that part doesn't really change the surgery. And if your conjunctiva is growing across the undamaged tenons,
Mm-hmm.
into a fairly normal configuration. I don't have any problems with we're taking it from the superior conjunctiva, even from a trabeculectomy point of view.
Mm.
I suppose inferiorly, technically, I think it's more difficult to take it. The lower lid doesn't cover the tenons. Once you take the conj graft off the inferiorly, I like to have the lid protect the surface while the conjunctiva is growing back.
Mm-hmm.
So I think it's a lot more uncomfortable for the patient.
Mm.
I've certainly seen tenons granulations occur. I'm not sure whether you've seen that, but yeah, where the tenons has been damaged and a granuloma has formed,
Mm.
and they can be a bit annoying as well.
Sure. Hmm.
Uh, yeah, so I don't take it from inferiorly, but they will be my thoughts on why I don't take it from inferiorly.
Hmm.
Mm.
Yeah, I think ergonomically, I'm guessing it might be a little bit easier to just infraduct the eye and get the superior tissue as well.
There's more
But
tissue up there.
right, I think it
Yeah.
might be that that's just we're all trained that way as well. So there might be some tradition associated with it. But yeah, I think there are some practical reasons as well to go superiorly first.
If you enjoyed this lecture so far, please subscribe to http://iop.vision. I hope you enjoyed this series as much as we have putting it together. Thank you.